takes, what, 21 hours for a regular primary care doc to do everything they're supposed to do? 21
cited
hours
the
a day.
article, probably. I took advantage of the existence of the article.
So, and last time we talked about patient-centered medical home, and that's sort of the why we do this stuff, because it decreases health disparities, it does the triple aim and everything else. But, so that was the why. David's going to give us the how. And he talks about transforming your practice, and it really is a situation where you really have to transform. It's not this tinkering around the edges. It's really transforming. So he's going to talk to us about the 10 building blocks of primary care, of effective primary care. So I'll hand it over to you, David.
Awesome. And I got the camera working.
Oh, okay.
I did it. Where'd it first? I see name tags, which is great. I was here last year.
You were here last year, but with the group that's up with
So
cohort
nobody,
one.
I haven't, nobody's familiar.
Nobody, no repeat.
Okay. Do you mind just going, can we go around the room and just say name and where you practice? Yeah.
Okay. I'm Laura Barr, and I practice in Millersburg, which is a rural community.
Great.
I'm Kit Belen from Altman Family Medicine. So I was in Canton in a residency program, so I'm faculty at the same time as primary care.
I'm Kevin Baldy, and I practice over at Akron General.
I'm Diana Kingsbury, and I'm a postdoc here at NEOMED.
I'm Rebecca Fishbein, I'm an assistant professor here at NEOMED. I'm Vanessa Worley, I'm an assistant professor at Mount Union Physician Assistant Program. And I work clinically a few shifts a month at a staff here in West.
Okay.
I'm Jana Corson. I work at Director of Children's in East Akron.
Great.
Patsy Icky, I'm a PA program director for the PA program at Mount Union, not currently clinically practicing.
Mike Peronish, St. Elizabeth Family Medicine Residency.
Great.
Karen Kirk, Seymour Barber and Family Practice Residency.
Okay.
Patrick Frost, Johnstown Community Health.
Maria Cole, Youngstown Community Health.
Okay.
Misty Wall, Youngstown Community Health.
Great. Okay, cool. So kind of most around the area. That feels closer to. So I'm in with Nathan and Cleveland at Metro Health.
And I should say, he's actually on paternity leave. He just had another baby, so we're really fortunate to have him here.
Yeah, this is my vacation from paternity leave. So good luck. See you later. All right. So thanks for the setup, Nathan. So less tinkering, more transforming, and so this morning in an hour and a half, or until 9:30, in a very interactive way, hopefully, we'll talk about the methods for how we came up with these building blocks of high-performing primary care, because in a way it was a little more artistic than scientific, but there is a little bit of science in there. Then I'm going to walk through each of the 10 building blocks. In an hour and a half, going through 10 building blocks is probably too much, but so if there's one to really focus on, one or two or three or four that you want to kind of stop the line and say, well, tell us more about that, we can improvise and dig in there and talk more about best practices for a particular building block. And then we're going to hopefully kind of address our own practices and think about, well, where do these building blocks fit in with there. So I will show you a picture of the building blocks so you know I'm not just kind of talking about building blocks. We made this cool graphic. But before I go there, so part of the science/art of coming up with the high-performing building blocks of high-performing primary care was our group visited 23 sites throughout the country, including as far down south as Alaska, as you see that, which I got to go hang out with for a month, and Nathan's talked about it. His cousin/college friend. And so we went to each of these practices and we tried to figure out, what are the workflows, who does what do the teams look like, where do they do it, what are their patient populations like, is there something specific about their their leadership or their payer mix that allows them to be great. How did we decide on these 23 sites? Well, here's kind of the arty, not so scientific part. We really just asked around. We were like, you know, at conferences and just with people in our circles, hey, where are the best, you know, high-performing practices? Where is the most joy in practice? And so the title of the article was In Search of Joy in Practice. And so from that, we developed these 10 building blocks. And like I said, I'm going to sort of try and go through all 10. But they're the order and the foundation of that first row, then that second row, all that is intentional. And so that ground row is engaged leadership, data-driven improvement, empanelment, team-based care. And so without those 4 building blocks, the whole thing falls apart. And so maybe we'll spend a lot of our time there. But then we get to patient-team partnership, population management, continuity of care, and then the 8 and 9, prompt access to care, comprehensiveness and care coordination, and then lastly, once you got all the whole 9 building blocks, you can put that 10th one on there, which is the template of the future, which means you go to work, and instead of your template of visit after visit after visit after visit, you spend your 8 hours with your team doing all the things that make the most sense for the health of your panel of patients. Because, you know, probably doing 20-minute visits back to back to back to back to back, or 15-minute visits in some of your cases is probably not the best thing that you can do for the health of your patients. So then I was also involved in a more scientific study where this was with another group at Stanford, where we had access to this database of commercial claims. It's this huge database, or what did I say, 40 million patients attributed to over 53,000 practices. And from this claims database, we were able to find the grouping of high quality practices. So which practices had patients with the highest quality scores. And we were able to find this group of the lowest cost per capita, so who had like the fewest, you know, lowest cost claims for their entire patient population. And then we figured out, well, which practices were in both groups, and we called those practices high value practices. Yes?
When you say high quality, how are you measuring that?
Yeah, so in our case, it was different type of like HEDIS quality scores, like colorectal cancer screening, diabetes, A1C greater than 9.
Not patient satisfaction?
No patient satisfaction, yeah. Yeah, just claims database, that's a great question. In fact, we had to like do a whole like 14-page appendix to really like, we created a quality composite score and risk adjusted it and stuff like that. But yeah, that's a great question. So we were really looking at like HEDIS quality scores. And so, yeah, so low cost, high quality, where they overlapped, we called it high value. And so we had 100 or so practices that fit into that category. We chose to visit 12 of those based on kind of spacing them across the country in different sizes to get a good mix. And then we also visited 4 average value practices. So folks that are practices that kind of were average quality, average cost, and the same overlap there. And so, and the folks we sent to visit those practices were blinded to whether it was a high value practice or an average value practice. And their instructions were just go and take notes on what you think are the attributes of this practice that would make them high value. So we didn't tell them which, you know, what you're doing. We're saying, you know, go to this practice and you identify the attributes that are out there. So it was really challenging. It was like a 4 or 5 year thing. I sort of came in at the end. And from all that work, there were 6 attributes that were identified that kind of stuck out at the high value practices that weren't so much in the average value practices. And they pretty much fit into the building block construct. So this is just meant to be kind of background. And I identified the block where they kind of line up. And you guys have my slides too, so I won't spend a whole lot of time. The ones that stuck out that weren't in our 10 performing building blocks were balanced compensation. So this meant that in addition to being salary linked to RVUs, your salary was in some way linked to value or quality. So the practices that were in the high value group had that more often than the average value group. I think the average value group didn't have that at all. Careful selection of specialists. So this was kind of outside the scope of our high-performing primary care building blocks, but was really important for value, as you can imagine. So what that means, and you guys, see this every day, where you are selecting specialists either based on they're the only specialist there, or like there are two specialists and one always does surgery and the other one thinks more about it and gives you more kind of conservative opinion. So that's what that meant by careful selection of specialists. And then the third one was this idea of decision support for evidence-based medicine. So the site visitors notice a lot more things like best practice alerts built into the electronic medical records that we didn't fully appreciate in our high-performing, our joint practice work. But that was something that stuck out. Any questions on this? In the back? Yeah, you're thinking about a question. No? Okay. I saw a flinch on your shoulder. Yeah, Nathan.
I remember that there were a few things that weren't linked that you were kind of surprised about.
Yeah, that's a good point, and I don't have that on a slide. Yeah,
Yeah.
I mean, yeah, it was very interesting because they came up with 13 attributes, and there were other attributes like co-location, which I love and we'll talk about.
That was not,
And there were negative results, which you'd think would disprove the whole thing, throw the whole thing out, but I'm not ready to do that.
Yeah.
But yeah, no, you're right. Definitely selective focus here. Yes?
I'm not sure if you said that, so I'm just wondering why there was 4 average sites versus 12.
You know what it was? So the group decided that it was a little awkward. And that was it. So we were trying to find these sites, and we came up with this elaborate ruse of hey, we're visiting your site. You might be a high value site, or you might be an average value site. And I think ultimately when they were developing this, just felt uncomfortable reaching out with too many of the average value sites and convincing them that they may or may not have been a high value site.
Did you let them know they were average value up to the time?
I don't think they did. Yeah, I do not. Yeah, and it's a great, yeah. In fact, in the sites, I did see the unblinded list of the sites, and I'd never heard of any of them. And so super interesting. So any site in the country could be one of these sites. Yeah.
Is there a strength of correlation with each of these measures for how well it predicts?
Yeah, there is. I didn't include that in there, but yeah, I mean, as you can see, super small sample size. So we were really looking at just p-values to decide, what made this list. And so, some were more statistically significant difference than others, but they all tested out on this list. But yeah, no, we didn't look at a specific correlation.
Is there any correlation with the patient profile too? For this high value sites, are they mostly Medicare, Medicaid?
So this was it was a commercial claims database. So yeah, a lot of commercial payers in this group, which is 2009 to 2011 we're looking at. So obviously, the landscape's changed a lot, where there are a lot fewer patients who are commercial payers or who have commercial insurance.
So maybe have different patient behavior too.
Potentially, yeah. We tried. All right, well, let's keep going with the building blocks, because we get it all into the methods, very problematic methods there. But it was a really interesting study. It was cool. They had to publish it. Perfection being the enemy of the good kind of thing. So block number 1, engage leadership. So you all, some of you, I should say, work in. I guess to show of hands, how many of you work in a system? Sounds like many of you work in systems, but not everybody. So in your system, is there engaged leadership? And I'll talk about what I think that means. In your practice, if you're not in a big system, the engaged leadership piece is obviously much more obtainable. So what I mean by engaged leadership in this case, so does the leadership of your system understand what primary care is? And one awesome definition of what primary care is the Barbara Starfield 4 pillars of primary care. So primary care is the 4 C's: first contact care, continuous care, coordinated care, comprehensive care. If the leaders of your system think that primary care is just meant to generate referrals, to specialists and surgeons, that's not engaged leadership, right? That's not the kind of leadership you want. And that's not going to give you a high-performing primary care practice, or at least it's going to be a struggle. So that's where I put together engaged leadership. Really as simple as that. And sometimes it means that your leader has to be a primary care person, but really not always. You know, there are lots of examples of surgeons who fully appreciate what primary care offers, or, you know, non-clinicians or non-physicians, right? Questions on the engaged leadership piece? Okay. Easy to say, harder to do, right? Come and have a seat, don't worry, it's okay. There's a whole front row. I was late too, there's traffic.
Yeah.
That's what I saw. So, building block number 2, data-driven improvement. So data-driven improvement, and I have sort of two just pictures for this one. So the concept of data-driven improvement is you're given data in your practice that you can use for good and not for evil. So it means it's timely, it's bite-sized, it's clinically meaningful, like it's something you care about, right? As opposed to like, you know, some of the outdated metrics that you might not care about, like annual lipid checks and things like that, that tend to hover around a little bit too long. So it's clinically meaningful. In your mind, you doing better on this metric will help you save more lives. It's timely, so you're not waiting every quarter to get the metrics from the last quarter, right? Which is some of the problems with like claims-based data. It's your patients, so we're not talking about some big system-wide metric. We're looking at system maybe next to your panel of patients, and it will say there'll be a number, there'll be a numerator, a denominator. You're going to see it change based on the things that you do in clinic. So all that's called data-driven improvement. And we noticed in the high-performing practices that we visited that pretty much all of them had something like this. Yes?
I just wanted to say that, yeah, I don't bring this up, but you know, as part of Cleveland Clinic, I guess it kind of watered down to us, Actor General.
Yeah.
But the STAMP program, Strengthening Teams in the Advancement of Management of Populations, is kind of one of those things where you know, there's a focus on primary care offices and the satellite offices to like work with you know, patients that have care gaps. Right now we're limiting it to diabetes, but we're going to expand it to the cholesterol, blood pressure, what have you, so on and so forth. So we do have, you know, in our practice we've broken it up into a few different groups, and so maybe a little bit of competition there, but just to get people going. We have residents, faculty, you know, front desk staff, MAs, nurses in each of these groups, and we have a rotating pharmacist and social worker to go to the different groups and kind of talk about, okay, we'll bring like, you know, every week we'll have like 2 of the providers choose 5 patients that have care gaps each, and then we go over them and kind of see where we need to do in terms of improving their health, whether they haven't had an office visit in a year, or blood work hasn't been done. We have a workflow that Assure Drive that is updated, and that updated workflow goes to the one of the MAs as a point person. They contact the patient or get it to the front desk and so on and so forth. So there's like a protocol to kind of determine what's going on here.
That's great.
Why the patient's either not showing up or ordering labs. If there's an issue, bring it to the PCP. If the PCP doesn't do it, then, or if there's still no progress, then we talk about going to a social worker, ombudsman, care coordinator, or if they work at Actor General, employee health provider. So
nice.
It's pretty cool. It's pretty cool to show the ideas amongst the different groups within our practice. And so I think it's motivating everyone to kind of, you know, focus on this team-based effort.
Yeah, that's great.
Yeah, so
that's awesome. Yeah, and that's really exactly what you described is I think I have it as building block 6, which is panel management, population management. And what you're describing is so there's the out of control folks who are like A1Cs greater than 9, but then there's the out of care folks who are just don't have an A1C in the last year if they have diabetes for that metric. And so you're doing great outreach. It's awesome. And probably many of you in your practices do a lot of in-reach, which means like when folks come in for whatever they're coming in for, you're getting them up to date, you're closing those care gaps. But in order to do the outreach, you got to do exactly what you described. You have to have people with designated roles, protected time to be able to do that. Awesome. Cool. Anybody else have a data wall in their practice? We don't yet, but we're going to. It's by 2018. Yeah. Yeah. there are a lot of creative ways to do it, and then the question of like, do you put everybody's score up there, or do you just put the practice score? Certainly when you think about human motivation, one of the main driver, or a big driver, is not so much the incentive, which we've talked about a lot about, like the financial incentive, but the social norm incentive, which means that competition with each other, right? Like, which is friendly, like, right, exactly, but like, oh man, like I'm in the bottom, like on this metric. It doesn't necessarily mean you're a bad clinician. It means like, a lot of times folks go to outside labs, you gotta input them, you gotta create workflows around that, so it's a cool opportunity. And in the meantime, you might save some lives. Cool. And this, you put an emphasis here, is that this is even in the waiting room, which that's bold, right? Yeah. But, it's cool. All right, so empanelment, one of my favorite topics. So what does empanelment mean? So empanelment is really answering two questions. So from the patient's perspective, who is my primary care team or primary care provider? From the primary care team / primary care provider's perspective, who the heck are my patients? Right? And there's so many different definitions. Are we looking back like a year, 18 months, 2 years, 3 years? What counts as a primary care visit? If you see someone for a cold, are you their PCP now? Is the insurance company telling you, okay, these are your patients? So like, I don't even agree with that. There's no right answer, no easy answers. It's important to know it's complicated. It's always evolving, and you ought to have a system for how you think about it, because if you don't know who your patients are, then you can't improve their population health, right? You can't take a look at your panel and improve their metrics. You can only, you're really still stuck doing one at a time if you don't have a registry list of your patients. So this is what Nathan was referencing earlier. So there's this great study that I didn't do, but I adapted later on the third slide or something like that. So a primary care physician who has an average panel of 2,500 patients, so average range of age, cradle to grave, if they do all of the recommended preventive care for each of their patients, so for the 2-year-olds, they're doing the 2-year-old well checks and the vaccines. For the 52-year-olds, they're talking about colonoscopies and mammograms, etc. That would take 7.4 hours per business day if you work 48 weeks a year. And it was like pretty conservative estimates. Like a colonoscopy would be like maybe a minute to explain, right? Like in this study. In real life, totally, did your brother have one? Did your wife have one? Okay, go do one. Oh, you've never heard of one? All right, we're going to spend 20 minutes talking about this, right? And then the group followed up with that study to look at all of the recommended chronic care. So the A1Cs, the diabetic retinopathy, so explaining all of that. If your panel of patients had an average proportion of diabetes, hypertension, hyperlipidemia, etc., that would take 10.6 hours per day. So now you're up to 18 hours a day doing all the recommended preventive and all the recommended chronic care for your panel of 2,500 patients. And then they did another follow-up with acute care, and they added another like 6 hours or something like that. So what we did in our study was we said, all right, well, if you work 18 hours a day and you can take care of 2,500 patients, what if you only worked, what we work, which is 9.5 hours a day or 10 hours a day, 2,025 hours a year on average, according to some database. Then the reality is to provide optimal care for your patients based on those guidelines, you could only care for 983 patients. Right? And so the average panel size, not really good data out there, but it ranges around 2,500 patients. It's close to that. The reality is like nobody knows what the panel sizes are. And there's a nice study showing that 2/3 of family docs had no idea what their panel size was for all the challenges that we talked about. Our average panel size in our system is 1,100 unadjusted, but when you divide it by people's FTE, like how many sessions they work, you're getting closer to like 1,900. And we've got a lot of new providers, so we'll probably continue to get a lot of new providers, but if you took out the new providers, it would bump up a lot. So 983 patients, that's how many you can take care of. Now, what we did, we said, well, maybe you don't need a primary care provider to explain a colonoscopy. Maybe you don't need a primary care provider to do outreach on someone who's missing an A1C, et cetera, et cetera. So if you took half of that work and shared it with the team, now all of a sudden you can provide optimal care to 1,947 patients. And as you all know, I mean, that is what we have to do. I mean, that is so important because we can't all become concierge, providers and say, hey, we're going to cap our panel at 983 patients because there are just not enough of us. Which will change with time, potentially, but for now, there are just not enough of us. Any questions on that long division? Can you believe it? You buy it? Well, we did our study on top of like some interesting math from another study, but it's more conceptual. Yeah.
The 2025. When I divide this out, this is about a 45-hour week.
Yeah.
Based on 45 to 47 weeks per year.
Yeah. Thank you for doing that math. I had forgotten it.
I suppose my trouble is, are they counting part-times in that average? Because I venture to guess that the average primaries, are they counting only clinical hours? Or are they counting
So the database,
schedule?
I couldn't remember off the top of my head if it was the AAFP database or the ACP database, but I'm pretty sure they were looking at full-time. Okay. But you don't, it doesn't feel full-time enough for you.
Maybe not.
Okay, that's fair. Yeah, maybe need a vacation. Yeah. No, that's fair. But pretty close. I mean, 45 hours a week times 47 weeks. I mean, it's a lot of, it's a lot of hours. Maybe take lunch. I know, right? Yeah. No, I hear you. I mean, maybe considering how much of that is patient-facing. No, but your point is for sure well taken. So then this is a little bit tangential, but it's something we've been thinking a lot about right now, which is this whole, what is the ideal panel size? Everyone wants to know. Every conference I go to, what's the ideal? What's your panel size? What's your panel size? What are you guys doing? What do what's your panel size? And so, a lot of that focus has been on like just the one number of the panel size. And that's always felt pretty misleading to me and to others, right? So there's all sorts of risk adjustments now they do. All right, your panel's sicker, so you're 1,000 patients is really worth 1,300 patients. And how did you decide they're sicker? Well, we looked at like HCC coding, right? Who has heart failure and diabetes and stuff like that. Well, what if they're poorer? Oh, well, that would be a whole other adjustment we don't really know how to do. Wait, what if they're wealthier? Because it turns out wealthier patients actually take more inbox work for providers based on this other study that we did where we looked at, MyChart messages and phone calls and stuff like that, right? If you're taking care of a wealthier clientele, you're actually getting more work that's coming at you. If you're taking care of a more vulnerable clientele, probably the work that needs to be done is more of you and your team going out there. They're not necessarily coming to you as much. What if they have more opioid use disorder, right? Is that, more or less valuable than heart failure and the HCC? So all that said, we figured if you adjust for one risk factor in your panel, then you're overemphasizing that one risk factor and missing everything else. And so what we said is we created this grid and we said, well, the question is can you care for your panel in a just way, in an equitable way? If your panel size is greater than 1,900, that categorizes as high. But if your third next available appointment is in a week, you're probably okay taking more patients. If your show rate is less than, or is between 16 and 24%. So we created this grid and we said, if you're 2 or 3 in the high category, your panel is closed. If you're 2 or 3 in the medium category or tied across, your panel can probably take 1 patient per session. And if you're all in the low category, predominantly in the low category, then you can probably take 2 new patients per session. So that's what we're doing in our system right now. And basically trying to make the point that panel size is just a number. And there's a lot more to it than kind of this over focus on the one number. A little tangential, sorry. Any questions on that? Do you guys get this question a lot? Panel size? Panel size? Not as much. All right. Building block number 4. So the 4th foundational building block for these high performing practices is now finally we're at teams. So this is what a team looks like. So this is a picture from South Central Foundation, Alaska, which Nathan has talked to you about, right? So teams look really cool, when they're working well. This is really what a team. I'm such a big fan of co-location, and it's some of you have co-location in your practices, which means basically the providers and nurse, medical assistant, everybody kind of sits in the same space. So if you don't, there's a lot of resistance because you have your office. You're like, I make some important phone calls in there. I need quiet to write my notes, right, like that. But then once you move to this, probably you don't want to go back. Because it turns out, when nurses, when folks are taking calls about your collective panel of patients, all of a sudden, like, you're there, not only building trust for seeing how they're handling those issues, but like if they need you, you're right there, and you can just handle it before like this whole 6-thing phone tree, ends up in your inbox. So that's part of it, and it's this concept of trust and all working together for the same cause. There's some other key features of teamness, which is based on this work, but also other studies on high-performing teams, which is this co-location concept, but also protected time to be with the team. So if your practice doesn't have a practice meeting, it's really hard to build a team. And everybody's been to a bad meeting, but if you've been to a good meeting, such a thing is possible. And it really makes a big difference. So if you go to a meeting which is not meant to be, all right, here are the updates to the clinic, okay, see y'all later, something that could have been emailed or hung up in the staff room or whatever, then that's probably not a good meeting. But if you're a meeting, hey, a couple of you sent me some agenda items before this meeting, we're gonna try and troubleshoot, how do we manage patients coming to the front desk angry about whether or not they got their opioid refill? Right, let's troubleshoot this together. All right, from the receptionist perspective, what are you seeing? From the medical assistant, what are you seeing? That sort of thing. So if you're using meetings for this kind of brainstorming and troubleshooting together, they tend to be really effective. So meetings are kind of the big level. Huddles are those small mini meetings right before the clinic. Like, all right, we got our 20 patients on the schedule today. Like, who's going to cause us trouble? What's going on? What should we be looking out for? What's going on in your personal life, do you have to leave early, is there anything on your mind that, we should know about? Work groups is like, exactly what Kevin was describing. All right, once a month or once a week, this group is breaking off and trying to troubleshoot what are we doing about our folks who are overdue for their A1Cs. Parties, really important. Whether it's like a clinical party where like, all right, we hit our 59% colorectal cancer screening rate, pizza party, or just like baby showers and retirement parties and that kind of thing. I mean, these are all things that make teams happen. So that's the protected time and space concept. Shared mission, vision, and goals. So it turns out that most of the people you work with join the healthcare profession to make people healthier, not just the providers. And so that's really fun to kind of figure out and give everybody the opportunity to do that. And so that's part of what creating a shared mission, vision, and goals, where it's not just the providers sitting in a room kind of coming up with this stuff, but where everybody's doing this together. Team orientation and training. So you can send medical assistants off to some training where now they're going to learn how to call patients and tell them about their overdue A1Cs. But if they come back to your practice and nobody else went to this training, nobody else is going to let them do this new work that they learn how to do. But if you all go together as a team and all learn together about this active, panel management outreach, then you build this trust and this chance to let everybody kind of participate in care. So that's the concept of team training. And we've seen it both ways, right? Where people go off to conferences, get trainings, et cetera, et cetera. And not everybody needs to go and learn how to give flu shots, but some of the stuff that is new and novel, I think, is the team training concept really works. Strict rules about culture, not procedures. So you don't need a rule about, all right, what's our no-show policy? Is it 15 minutes? Is it 20 minutes? Is it 25 minutes? Like, you don't need that. What you need is rules about culture. All right, so people are respectful to each other. In some cases that means people call each other by their first name. And that was something we saw in high-performing practices. So that's more of a strict rule about culture, right? Where people are just respectful and nice to each other, where you can do team steps type of stuff, or if someone says to you, I'm concerned, then you listen to them, right? You stop what you're doing, you listen to them. And procedures, right, is something else. Other concepts that folks have noticed that have really been important for their teams?
I think non-hierarchical situations are really important, and that goes along with the co-location and the culture. I have one quote that I just love: "Culture eats process for lunch."
Oh, I love that. That's your
that's my other cousin. Yeah, I mean, I think it's so true. If if the culture is there and everybody realizes what the culture is, then you don't have to go over all these. The person was 21 minutes late, and so.
Right.
Yeah.
Right. Exactly.
Right.
In fact, I joined our late. That's the example I always give, because when I first joined up in our system, it was like, I'll be on the late policy committee and I will sabotage that thing right to the ground. And I'm here to make sure there's no policy. Because it's just silly. We got 30 sites. Like, we don't need some universal late patient policy, right? So basically, the late patient policy was there is no policy. Decide as a team what makes sense.
Do you feel pressure from your organization to, especially when you're under the microscope for productivity,
Team
if
meetings.
you have things like team meetings,
Yeah.
which are not getting revenue for
Right.
that, and maybe going towards the bigger picture of putting something in the beginning to get a better product, but how do you negotiate that?
Yeah, that pressure exists, and it really, it goes back to building block number one, this engaged leadership concept, but you're right. It's always, seems to just come up every few years. Oh, why are we doing these meetings? But they're so important, and you just hope that anybody who has gotten an MBA who's in leadership, they do this in school. This is part of their learning, is how teams work, and how effective meetings can be so influential. So yeah, that pressure always comes up, and kind of always have to be ready to, I'm towing that line between you idiots, what are you doing? You're like, respectfully, don't take our team meetings. This is the one chance we get to talk to each other.
Have you looked at turnover? Because it seems to me that the turnover would be less in a practice where everyone feels like
They
have a good relationship with their coworkers, and so it just would be interesting to see turnover rates, because ultimately for the system that's a lot of money to continually hire folks in.
Right.
And have a lot of turnover.
And there's this great statistic that will help you with leadership, which is one physician, for example, that leaves costs $600,000 or something like that in recruitment and the lost productivity time and stuff like that. And a lot of times that's related specifically to burnout, but burnout, another study our group did was looking at teamness and burnout, and on folks who are on a higher teamness scale, there was less burnout. So for sure, you can always turn it back to that. It's a great idea. Yeah. Great. Okay, so those are the first 4 building blocks. They happen to be the hardest. They happen to be the hardest. I think we're in this world right now, Nathan and I, where we're really trying to build up number 4. And we're starting just like this, in my mind. This is where we're going. Still got a long way to go, but I think that.
Yeah, another point I would make is that, and this is what they discovered in Alaska, is the structural, your physical space makes a difference.
Mm-hmm.
If your physical space is so separate that everybody has their separate offices and so on, it can really be difficult to do team-based care. We just moved to a new site where everything is so separate that it does make it really difficult. And so we're trying to figure out ways around that. But so if you ever are involved in a new building project, I would strongly suggest you.
I've got blueprints.
Yeah, that's big.
Yeah, I've got blueprints. These are the blueprints. Yeah. I mean, these guys thought through everything in terms of their, architecture to create teamness. It really did. So from the medical assistant's workstation there being eye level with someone standing and things like that. I mean, just to create this, togetherness. It's very cool. And the view, which you can't really see all there, but there's, there's a mountain back there.
We don't get that included.
Yeah. Okay, so our foundation of leadership, data-driven improvement, empowerment, team-based care. Now we can move to our tools for patient-team partnership. So Kevin really expertly introduced the concept of panel management, which in some practices is really a dedicated person as the panel manager. In our practices in San Francisco, we would divide up the time of the medical assistant. So many of our providers weren't there 10 sessions a week, and so the session that they weren't there, the medical assistant who predominantly worked with them would be protected to do panel management outreach to their panel. And so these are other concepts of anything basically except for the 15-minute visit, right? I mean, there's still maybe a role for a 15-minute visit, but 30-minute visits are really good too, right? Emails, if you have protected time for them, which we'll get to in Building Block 10, can be a very effective way to build a partnership between you and your patient. Phone visits, nurse care manager, so a very popular model right now is the high-risk care coordinator model. Often this is being done before, before those first 4 building blocks, and so you'll see some really bad examples of that. Often a lot of this stuff is done without that foundation, which is why the foundation exists, because it crumbles apart. Group visits are really effective and lots of good data for diabetes group visits, for centering pregnancy group visits. Health coaches, so this is a concept where potentially a lay health worker or even a peer coach is trained in motivational interviewing and really designed to help people come up with their own goals for their health and their own action plans. And action plans being very specific to a time, a day, checking in. All right, how did that go? How confident are you that you can keep doing this? All right, if you're not that confident, what would make you more confident? That sort of thing. All that's health coaching. I think I touched on all those different things. So that's the concept of patient-team partnership. Population management. So how do we care for our panel of patients? Well, here's your panel. Probably all of them deserve a little panel management. Maybe not all of them. Maybe there's a few that slip out of there. But that's kind of looking through an entire registry and seeing where those care gaps are. Whether it's outreach, mail, email, my chart, or inReach. So when people are in there for whatever reason, you see their best practice alerts, you see what they're due for, you get them up to date. A select population of your panel could probably benefit from health coaching. And even more select, it could be in this, this oft quoted, 5% accounts for 50% of costs or work or whatever it is. And so this is obviously, there are a lot of programs like this throughout the country. One of the reasons they fail, as I mentioned, is they don't have that foundation of the building, the 4 building blocks underneath. The other reason they fail is what some programs fail to realize is the 5% that accounts for the 50% tends to change every year. And so you can focus in on that 50% from 2016 and oh great, 2017 was a great year for them, but that could have happened without the regression to the mean essentially. Now some in this group are going to be, and you're thinking of them right now, right? Oh no, every year they're in that group. But many folks really they have a rough couple years and then things level out for whatever reason. So that's one of the trickier parts, and everybody's out there trying to sell their artificial intelligence risk calculator to tell you here are your patients, but it's pretty tricky. Any questions on this concept of kind of risk stratification across your panel and thinking about your panel in kind of different ways? So this is, you've got your team now, you've built your tools for a patient-team partnership, and now looking at your panel, you're segmenting the population, you're building this pyramid of, all right, who needs the most touches, who needs this kind of touch, that sort of thing. Number 7, continuity of care. So remember, this is one of the 4 pillars from Barbara Starfield. I think it's the second. So first contact care, continuity care. Now this one's tricky because there's not a whole lot of innovations out there to optimize continuity of care. I mean, I think the first step, which we're not universally doing yet, is measuring it. So there are 2 measures of continuity of care. One is from the patient's perspective. Their denominator is all their primary care visits. Their numerator is their primary care visits with you, their PCP. You know, so when they want to see you, how often, or when they want to see someone in primary care, how often is that person you? And you can include urgent care visits in their denominator, or you can exclude it. You can include emergency room visits, however you want to do it. But just some measure there of the patient perspective of continuity. And then the other measure is the provider perspective of continuity. So on your template for the day, so 20 patients that you saw, how many of those patients are quote unquote your patients? What's the goal? You know, that's still a little bit tricky. 80%. Sometimes it's good for, you know, patients to see other people. Sometimes it's good for us to see other people. It's all good. And often, you know, the anytime you measure something and you put it in front of like the leaders and the board or whatever it is, then all of a sudden, oh, we got to make that higher. And I think that's really helpful for us in primary care because right now the focus is so much on access. You know, you hear commercials, you can get a same-day appointment and 45 minutes away with some person, you know, you never know, right? So like that, so that's been this emphasis, and we know that continuity of care leads to better outcomes, lower costs, more joy, better care. Any questions on continuity? Part-time providers, big challenge. How do you take 2.4 providers, combine them into one, say, all right, you're both the leaders of this panel. So it's really tricky. I mean, it just sounds like that's the right thing to do, but logistically, how does that work? Yeah.
I'm thinking another variable that enters into that is the changes in insurance and contracts and your patient panel under those contracts. And and that can be extremely disruptive in the continuity process, just from a business management standpoint.
Right. And you still feel like you're experiencing that quite often now?
I don't know about often, but enough to be potentially disruptive.
Yeah. I think that's a good point, because my wife has actually had a number of patients that they changed insurance, they had to leave her, and now her panel's closed and she can't get back in. So and she says, you've got to tell me somehow, and then I'll say yes. But
yeah, right.
They never get past the first call.
Yeah.
I mean, how do we as institutions sort of prioritize this continuity of care?
Yeah, that's interesting.
So.
Anybody feel like they've solved the part-time provider challenge?
I'm part-time in my clinical
Yeah.
practice, and I have the patients that are paneled to me, and I'm their PCP, I take care of. So even though I'm there 3 days, you know, I have a colleague who's there the same amount of time. She has her own panel, I have my own panel. But that's just how.
So 3 days, is that 6 sessions, 5 sessions?
I'm not, I don't.
Like how many half days, I should say?
Oh, well, technically it's 2 full days, and then I have like a longer 3rd day.
Okay.
So,
that's pretty good.
yeah.
And that's great. I think that's probably the part-time provider answer is like, that should be part-time rather than,
Well, yeah,
you know,
it's not like 1 or 2, that's just too hard.
Right.
You know, it's like trying to balance clinical time with academia is hard because they're like, well, you need to be here all the time. It's like, listen, nobody wants to hire a nurse practitioner or PA for 1 day a week or a PRN. It doesn't exist.
Right.
And it defeats the purpose.
Right.
Like, I want to know about my patients.
Totally.
And, you know, my medical assistant, you know, she texts me on days that, you know, I'm at
nice.
you know, doing my, as I'm sure you guys all do, it's
Sounds
like
like
your
you've got a
hands all
good
different
team,
times. But that's the key to it, is that
Yeah.
you have to, and I've been with this practice for 18 years, so I think we all know how we work.
Yeah.
The biggest hurdle was going from private practice to an organization, going to the dark side.
Right.
And I think that was the biggest one, but I think they saw, I've known most of these patients for 18 years.
Yeah.
We want her to stay, we'd rather have her than hire somebody new that
Right.
doesn't know our patient panel
Sure.
and how we work, and so it's worked out. And I think that's individual to each kind of practice
Yeah.
too. But that's how we've worked it, so we all get paneled with our own patients, and then we have our own time each week for our
That's great.
care gap,
Yeah.
that we
That's
take
great.
care of. And I have a great medical assistant that helps.
Yeah,
them.
well, I'm hearing definitely some themes that resonated of your teamness of being your sessions were spread out through the week, it sounds like.
Yeah, so they
You've
don't
had
look at us as
continuity
like the
with them.
2.4 provider. They're
Right.
like, if you're Denise, then Lisa, and
Right.
take care of these
Right.
people.
That's great. Okay. Access to care. So purposefully, it's way, down the line. Access is so important in primary care, but it's got to be balanced with continuity. We know the stories of emergency rooms crowding with people who could have been cared for better and for less money in primary care. This is a really old study that I should probably stop putting in here at some point soon, but this study from now 15 years ago found that these researchers just got a phone book and started calling primary care practices after hours to see what would happen, and 58% of those calls went to an answering machine at 5 p.m. that said, for example, please call 911 if this is an emergency. So no, not even a call service.
Yeah.
Super interesting, and you compare that to kind of high-performing systems in other countries, and that's totally crazy. But really challenging, right? If you have a solo practice, this is why, right? The dark side of the system is one of the reasons that it's exists. So, like continuity, the key to improving access is measuring it, or a key is measuring it, and my preferred metric for access is called third next available appointment. Have folks heard that before? Okay. Okay, so third next available appointment is if I'm calling today to see Dr. Arjun, how many days out is the third next available appointment? And so why not the first available appointment? Because if someone if you're booked out 3 months and someone cancels on your schedule tomorrow, I'm reporting your first next available, oh, his access is great, 1 day out for first next available. So it's totally misleading. The same reason for the second. So the third next is a little more logistically challenging to get the metric, which is why some systems abandon it, but it's so good. It's so good. I still feel like I'm making the case in papers and with my own system, it's this is the metric. Stop looking for other metrics, but it's a great metric. So if you're measuring panel size, if you're measuring access, if you have a way to measure demand, which is also really tricky, it's how often are people calling for appointments? Yeah.
Our system has looked at third next available for new patients.
Oh, great.
The problem I have with that is that's not reflective of our third next available for existing patients.
Right.
And so what's your take on that type of a twist?
Well, you can't, you like you're feeling, you got to measure the other one.
Okay.
You can measure the third next for new patients too, but the focus should be on the third next for the established patients. Right. So before I got to the system, not to toot my own horn here, but they had some metric that they were all looking at that included because someone had told them at one point this is the metric, but it included block slots, so everybody's access was amazing. Right, exactly. Everybody's access, we don't have an access problem. And I'm nobody can get those appointments. They're held for 24-hour, urgent care or whatever, 48-hour Medicare wellness visit slots, new baby, discharge slots, stuff like that aren't really, of course they're going to be open in 3 days because they're blocked and you can't schedule them to the 24 hours before or whatever it was. So a true third next available for your patients is what you want. But it's cool to look at the other one too. Yeah.
So that typically will exclude appointments that are meant to be for same days also?
Yep.
Okay.
Yep, intentionally. Right. Because you can sort of hodgepodge work around your access problem by creating these same day appointments, but if you've got a 3-month backlog, you got a supply-demand mismatch. Or you don't necessarily have a supply-demand mismatch, you just have a backlog problem. Because if your backlog is always 3 months, then your supply and demand is probably equal. You just gotta clear down that backlog. Which Mark Murray, this big access guru, would say, all right, everybody's working weekends, working lunches, you know, working evenings until the backlog's gone. But we would argue, really, it's, you know, probably most of those people don't need appointments, and there are other ways to kind of meet their care needs without, you know, setting up 1,000 face-to-face visits. And so, yeah, that's all those points are there. Build capacity enhancing teams and services, so that's phone visits, telephone visits, team, group visits, et cetera, et cetera. And then recognizing this tension between access and continuity. And like Nathan alluded to, I mean, it's really the patient's choice. If they want to see someone tomorrow, 45 minutes away, you know, you can't be like, no, you know, you have to see your PCP, but many people will choose to see someone they're familiar with. Especially if they've known them 18 years. Right. So building block number 9, 2 big terms grouped together, comprehensiveness and care coordination. So we know our role in the system tends to be this one that people allude to of like the quarterback. So this is this kind of like an essay in New England Journal of Medicine where they tracked, all these lines represent the care for one patient in some time interval where the PCP at the center is, you know, phone calls between PCP and the patient, between the PCP and the surgeon, the hematologist, emails, procedures, offices, so, you know, PCP, patient right in the middle there, coordinating all that care. That is a building block for us, right? We can't just be in the office seeing visits, because this work is really an important part of the value that we give. And if your leadership doesn't understand that, right, that's a problem. Comprehensiveness further means that, you know, as a PCP, if every new problem that you're seeing, you're just referring to someone else, you know, you're not giving value to society and the people that you're taking care of. This is where that curated medical neighborhood comes into play too, so that's that careful selection of specialists. I think I might have stuck that in afterwards after that other study. You know, we tend to not round on patients in hospitals, but at the least there's got to be some interface there, some communication, so that they don't muck everything up for us. Referral tracking, so when you do refer someone there, like, do they ever make it? Do you know? Out of sight, out of mind? Is there a system to you know, track that down? Sometimes you're like, oh, thank God they didn't go to that referral. I just did it, you know, to make them happy. But many times you're like, no, they need to go. I need to make sure that happened. So that's all I have on comprehensive care coordination. Any questions on those big concepts? Yeah.
Also, patient-centered medical neighborhood. It's not only the primary care's responsibility to coordinate care with others, it's actually the specialist's responsibility to coordinate with
Yeah.
and that's when it's not just always the
Right.
here kind of
Totally.
You just have to talk to everybody else.
Yeah.
Cardiologist, nephrologist, again, with all the other
Exactly.
specialties.
Yeah. Yeah, and then there are these concepts of kind of like, all right, so when you're referring for a consult, do you want them to take over that problem? Do you want them to just give you some advice and send them back? And or, you know, is there kind of a ramp off period where it's like, all right, they've got CKD stage 3, you don't need to keep seeing them every 6 months with, you know, Chem 10 for eternity, right? So things like that. So that's all part of, right, exactly what you said, the medical neighborhood. How do we work with each other? And then building block number 10, last but not least, and certainly, you know, my favorite PowerPoint slide. So here's how we take care of our patients now. We do all this stuff on the side. Here's the future vision, right? All these different tools that you know, we're developing and sort of like tinkering around the edges right now. But in the template of the future, we go from this to something like this. So you show up at work, and rather than, you know, visit, maybe you need protected time for email and phone visits, maybe you need protected half hour with your medical assistant who's trained as a health coach or a peer coach to take care of a complex patient, and so that health coach medical assistant can later follow up with them. You need protected time to coordinate with hospital specialists. You need protected time for huddling with your nurse, because these are really the types of activities you would do if your job was to improve the health of your patients. And then you could actually take care of more patients. You're reaching so many more.
Sorry.
What's that, what'd you say?
I said, you mean it's not the job? Improve the health of our patients. It's not our job.
It is your job. We're just not in the position to do it as effectively as we could be. And this is kind of this concept of like, you know, if you blew up the whole thing, and what would you design? And it doesn't have to be this, because you could start at like 9 or 10, you know. but the concept of, you know, our template can't look the same if we're going to do all this other stuff. So there has to be this concept of a new template, a new measurement of productivity. And this is my concluding slide. And there's, I think, still 10, 15 minutes to talk if you want to. But in order to get from here to there, we really need a vision for transformation. It doesn't have to be this vision, but you know, we should be in our minds kind of sketching out what that future vision would look like. We know there are barriers, and it's not the way we're paid, you know, in an RVU-based system is not the only barrier. It's often cited as, you know, the big barrier, but there's still, you know, we're starting to change how things are paying, and, you know, that's driving transformation a little bit, but we're still stuck in this place where managers are counting something called productivity, right? And so we need to give them something else to count. We need to think through, like, well, all right, we don't want you to count our visits per hour. All right, what do you want us to count? Because it's not that easy. I mean, you could count, you know, your rate of your panel's colorectal cancer screening, but if you take care of a more challenging patient population, that's not going to be fair to you. So you could count the improvement from year to year. I mean, there are all these different things, but we have to start to develop, working with our managers, how do we want to be counted? And this is such a long journey, it will never end, right? So you have to find a way to celebrate the short-term wins with a pizza party or bowling or whatever. You know, because it's not, I mean, you're never going to get to the perfect place. There's always going to be things that come up, there's always going to be turnover, there's always going to be setbacks, so that you have to find a way as the provider and team leader to celebrate those short-term wins and recognize, you know, the improvements that you are making. The end. What do we do? 9:15. Should we dig into any of the building blocks from earlier? Is there any questions on how we got from there to here?
Question.
Yes.
For the number 2, data-driven improvement.
Yes.
In your practices, do you have like a dedicated IT person who will run those reports and kind of like get those data, real-time data or accurate data as part of the quality measures?
Yeah. So you're asking in these practices?
Yeah.
So what's interesting is there is, for us as, you know, clinicians, there's generally no such thing as accurate data. So, because there's always going to be some problem with it, or there's always going to be some problematic. And so there's this kind of joke, this 5 stages of data grief, which first is denial, that's not my data, then anger, who the hell came up with this crap, you know, and then bargaining, you know, well, if you just exclude those patients because they're mean, or, you know, whatever, they don't do what I say. What's next? Yeah, at the end there's hope, like, all right, it's something, we'll work with it. So, yeah, I've found that the waiting for the golden analyst to come, which is something we talk about all the time, I find that to be a barrier.
Okay.
And so the data exists, it's never going to be perfect, but at least it's something that you can kind of measure your own improvement to.
So your EMR is designed to just kind of like...
Well, yeah, I mean, we're getting there, but yeah, no, I mean, ours really isn't. We're getting there. But yeah, some of them are closer. It's amazing, like you'd think, I mean, it's all there. But yeah, you had each practice, every system where I visited and kind of, you know, traveled through and worked at has had to come up with their own creative ways of coming up with data. And that has included Excel spreadsheets. A lot of Excel spreadsheets, actually.
Because we recognize its foundation, right? It's right there.
Yeah, so
we're-
having good data is not the foundation. It's using data for good, not evil, is the like data-driven improvement. So the idea of kind of like measuring your work towards something is the part that's foundational. Because traditionally, in some of the systems that are not high-performing systems, what you'll find is that data is used to like find culpability. You know, like, all right, who's messing up our perfect memories, right? Like, oh man, your colorectal cancer screening rate is terrible. Like, what is the matter with that person, right? Rather than approaching it with curiosity, how can we help you? And so that's the concept of the building block. It's a really good question. So we're finally like an Epic. We have a dashboard. It's phenomenal because we have nothing before. You know, it refreshes every week. The denominator is based on whose PCP is whose name is in the PCP field, and so that's of course not perfectly up to date. It's like 82% up to date, according to this other analysis I did, which, you know, better than a lot of people in the system thought, I think, but still, it's like 1 in 5 are the wrong ones when you get this data. So, yeah, definitely I often cite these stages of data grief. Yeah.
Yeah, we have Epic as well, so and we're having issues with like residents not being named. Like, they have patients, but it's under the faculty member's name, whatever. But just wondering, just out of curiosity, on my application, do you guys use like Tableau or?
No, so well we have Tableau.
Yeah.
Which I'm starting to play around with. It's very pretty. But we have it's called the Cogito dashboard that is like a node upgrade for Epic.
Okay.
Yeah.
Huh.
Yeah.
Cogito.
Yeah. So ask your Epic people about Cogito today. Yeah. I mean, so yeah, in San Francisco, and actually in California, there's this program called I2I. Has anyone heard of I2I? So it's like the ugliest, like clunkiest thing, but it gives you exactly what you want. It's just like you pull it up and you're like in like a 1998 Excel spreadsheet. But it's exactly what you see the numerator, you see the denominator, you can pull up that list of patients so you can vet it, because you always want to vet it, right? Like, don't let anyone tell you the rate is 62%. Get angry, denial, all that kind of stuff, bargaining, all that stuff with them, and just get the chance of that. All right, you show me who my patients are that are overdue. You know, oh, they are overdue. But this one's not, so fix that, right? You know, so there's a huge opportunity. So when you get these reports, the opportunity to actually click and pull up a registry of the patients with a care gap is, it's part of it. But even if you're just creating data based on like, all right, you 10 people sampling today, I mean, that's something. Yeah?
So how close are you guys to getting to more of that future template?
I think we're,
Just out of here.
yeah, it's a great question. So we did not have this for a while. Now, I think we've got this. Engage leadership. Data-driven improvement, I think we're starting to do. So we've got that. We've got a new chief quality officer. She's on board. We're still have to talk down a few folks here and there. Like, no, good, not evil. Impalement. We started May 2016. Did not have that before. They were just like, it was just like new patient emphasis was there. The established patient was not there. It's like, we need new patients. Their RVUs are worth more. So we have impalement. Team-based care is where I think we have is our next kind of opportunity there. So there are teams, there are sites, right? But like they report up and they have a different mission, vision, goals than we do on like the different service lines, the provider service line and that kind of a staff service line. So I think that's aligning, but I think this is our biggest opportunity. And then, of course, like everywhere here, folks are doing things here, and doing things here and here and here, but it's not going to work until we get that stuff going. We've got a measure for access that we're using. You know, we're experimenting with telephone visits out of Bedford, so there's some template of the future type of stuff. And we have like desktop medicine, stuff like that, but it's not, you know, it's not the template of the future. Yeah.
Well, one thing I appreciated in one of the articles we had ahead of time was your statement about the new primary care practitioner would function as a team leader and not as a healer to always seek help. And this could kind of be a dissonance to why we went into primary care.
Yeah.
And I really appreciate that schedule template. I guess I'm just wondering, so much of how I've approached practice is building that relationship. And so I don't see as much relationship building in here. It's certainly a relationship with the team.
Right.
But when I hear about a patient or a situation, it's not as internalized as if I actually am involved in that.
Yeah.
Can you speak to that a little bit?
Absolutely, yeah. So I think our point was basically that as a clinician, as a provider, that in order to do this, in order to provide primary care for everybody, that we will have to give up that patient-provider relationship for some of our patients. But that's why it's patient-team partnership, because that opens the door for other people on your team to build a relationship with your patients. And so it's not going to be us necessarily as the person who has the relationship, and that's tricky. But the whole thing will fall apart if we don't open that door to let other people in, because there's just not enough of us. Yeah.
It's like a paradigm shift.
Yes,
like,
exactly.
Trusting your team that they're also equally responsible and they're equally caring and equally knowledgeable, that they can also take care of our patients.
But on the flip side, it's also feeling like you have enough understanding of the situation that you can render good judgment.
Right.
That's sort of what I was getting at. Like, you know.
Yeah.
Yeah.
Right. That trust that that you know, now with our perfect team and template and things like that, that if someone does have an issue that needs to see you, they will be able to see you. They will not get stuck in a phone tree. They will get to you.
So when I was in Oregon, we have like a team-based care.
Nice.
So I can trust our MA or nurses to at least know about this immunization. So the preventive care, we can trust that to them, and they can like really do it probably even faster than I am. Then they're also good with chronic care, like looking at who has like A1C and all the eye examination. But I always make it a point that I'm available for their acute care needs and also their complex care needs. So there's still that relationship that's there and trust, but at the same time, those things that I can delegate to them, like immunizations and preventive care and chronic care, they can do it very well. And of course, with social worker too, can also reach out to them.
Where in Oregon were you?
Eugene.
Oh, great. Cool. Oregon for one of these things. Oh yeah, Multnomah, in Portland. They do, I mean, Cure Oregon, the whole thing there, Cool.
With that relationship piece, I think the other thing is we can celebrate it when various members of the team start to develop that relationship with the patient. And, you know, maybe it's not. The provider has the same kind of relationship with so-and-so, really has connected with this person and knows them well, and we kind of all share in that relationship. But I don't know that all of our team members know how amazing that relationship can be.
Yeah.
You know, so when you see it happening, you feel like applaud it and celebrate it.
Yeah.
And I guess I just want to clarify, it wasn't so much the trust, because I agree with that, like we can't be the ones that hold it all. It's more just, at what point do we need to make decisions and make calls, and do we have enough of an understanding just by hearing things second and third hand? It's not that we don't trust the information, but we have we processed it?
Like how much information?
Like how do we learn to process it from
allows you to be
afar?
able to,
I guess that's
exactly, right. Yeah, it's tricky. Yeah, and I think with that as well, the celebration of the relationship is, you know, when you do an outreach and it ends up, you know, let's say you're getting people up to date for colorectal cancer screening, you end up, you know, finding an early cancer, you know, celebrate that, you know, medical assistant trained as a health coach, trained as a panel manager who's just saved a life, right?
Yeah, it's one of the things that is unappreciated in society and our healthcare system is when you do actually do something that's preventive, no one ever goes. I mean, I was giving the example, no one ever comes and thanks you for the vaccine that prevented them. But yeah, and
or the mammogram you talk them out of doing,
right.
so, you know.
Right. So those things are tough, and we need to recognize those in the day-to-day stuff.
All right, well, it's 9:30. Thank you so much for this and being a captive audience. And when it comes up, I put my, well, you see, you got the slides, so you saw my emails in there. My personal email, because like you, my work email just captures everything and puts it in the spam folder, so. Although my Gmail does that sometimes too. You want to pause it?
Yeah.